We're going to start the discussion portion of the day. Now, in addition to a lot of the clinicians and surgeons and doctors and such on that you'll be seeing and hearing from today, we thought it'd be a good idea to actually hear some of the authentic patient experiences. This year, we're including the perspective of three particular patients. And we actually videotape them talking about, well, their cancer journeys and the emotional aspects of their experiences, the resources they utilize to help them cope with the challenges, and lessons they learned as they take a look back. So we want to thank them for their participation. It's not an easy one. But Sarah and Ann, who, by the way, are here today. Sarah, oh, hi. I wanted to meet you guys earlier, but thank you for being here.
And Jay, is that you as well? Yeah, Jay's
here. Oh, Jay is here. Oh, hey, Jay. Hey, Jay. Well, good to see you here, Jay. So what we're going to do is start off with a quick introduction from each of these folks before I bring up some oncology and social workers and open up the discussion. So please take a look at the video screens.
Hello, everyone. My name is Ann Buckley. I'm 62 years old. I am a breast cancer survivor. I was diagnosed in 2013. I am 5 years past treatment and 6 years past diagnosis. There was a lot to take in. There was a lot of information coming at us all at once. I was also very grateful for everyone in my family who brought notebooks and wrote down things that were being said. I couldn't hear anything that was really being said. Each time I had an exam or each time I had a blood draw, I became fixated on what were the results, what did it say, and then having to wait for the results and wanting to know right away, and then wanting to know everything. And of course I couldn't know anything, none of us could, not trusting. I went from being this totally normal person walking around living a very active and full life to being an inpatient on London where people were very sick. And when I realized, even though I hadn't lost my hair at that point, I had not really suffered any physical pain, so to speak, it was a shock to myself to say, I'm sick. I'm really sick.
Hi, my name's Jay, and I was diagnosed in 2008 for the first time with lung cancer. It took more than a year before I had a good oncologist here at MGH. So I obviously came from someplace else, and in 2009 in the fall we understood that I had the ALK mutated gene. And I was stage 4 and had cancer throughout my lungs, lymph glands, etc. The diagnosis at the previous hospital was one that they actually told me I only had 6 months left to live. That was in the summer or thereabouts of 2009. By the time I got my diagnosis here with the actual mutated gene and confirmation of stage 4, I had gone from a fully employed, enjoying my life as a commercial banker to somebody who was totally distraught, losing my family, losing my wife, losing my children, never seeing them married. All those things were going through my mind. I immediately told my employer, went on short-term disability. On the 89th day, they terminated my employment so I could never get long-term disability, which I negotiated out with them. And I was just in horrible condition mentally.
Hi, my name is Sarah Dagger, and I was initially diagnosed in 2010 with left breast cancer. At the time of my diagnosis, I had just started rowing, and I'm athlete, and so it was part of my exercise regime. So when I got my diagnosis, I kind of was in, I don't know if I was in shock or what, I didn't quite know what to do about it. And my mother had died in 2006 of cancer for the second time. So that was kind of in the back of my mind. And obviously I would have liked to have shared my diagnosis with her and get her understanding or her, of what to expect and just her warmth and love and everything. But I didn't have that. For 6 weeks, I went through radiation, didn't think too much about it. I was tired, of course, and I would lay on the couch, and I didn't tell anybody at work. And during this first time of cancer, my rowing teammates who I just met were really supportive, and they put together a dinner tree for me. But my husband didn't want me to tell anybody I had cancer, and at the time, it bothered me, but I felt like, hey, I have breast cancer. I need to tell my women friends. So that kind of started the process, I think, for me, without me even realizing it, that I was having some difficulty with my cancer diagnosis. After I was a year cancer-free, really no big hoopla or anything like that. I just kind of continued with my life. I was dealing with other medical diagnoses, and in November 2016, I underwent a very invasive non-cancer surgery, which I think just was just more added on to my emotional and spiritual complexities aside from physical. Again, I didn't really do much about it, but things started falling apart for me, and I still didn't do anything about it. And I didn't know, emotionally and spiritually, physically, I was just like a wreck. Finally, after about 6 months of recovery from that surgery in May of 2017, I was getting ready to go back to work, and I found out I had cancer for the second time.
How about a round of applause for Jay and for Sarah and for Ann? So now we're going to welcome up Leanne Miller and Jen Delato. These are a couple of the people, the incredible people that you tend to lean on after the shock and awe of a diagnosis. Leanne is the outpatient melanoma and genitourinary oncology social worker at Mass General Cancer Center. She focuses her efforts on helping patients and their families process emotions related to a cancer diagnosis, much like we just saw on the screen. Jen Delato is a clinical social worker in the BMT leukemia and bone marrow transplant survivorship programs at Mass General. Her practice focuses on assessing and addressing the strengths and the challenges families face in coming to terms with their diagnosis as well as their treatment. So let's welcome up Leanne and Jennifer now. Hello. Good to see you. How are you? Hi. Good to see you. You guys, I don't know if you'll need the microphones. Yeah, you should probably hold in case. You okay there? You want to do one of those check 1 2s, like a broadcaster? Check 1 2. Hello. Check 1 2.
Hi.
Oh, okay. Yeah, welcome to my world. The videos that we just saw are just incredibly moving. And what comes to mind standing in the corner watching is, oh my God, there are so many different phases that a patient has to go through. A lot of the things you don't even think about, you don't consider. But the diagnosis is the whammy. That's what you've got to deal with initially. And we heard from Ann and Sarah and Jay right there. Talk about the diagnosis phase, and either one of you can jump in on that.
I mean, I think, can everyone hear me? Everyone but my family thinks I have a quiet voice. So we're good? Okay.
Well, you do have a quiet voice.
Not to my family.
You could have been a librarian.
I think no one goes into this expecting a diagnosis. People tell me, I'm so sorry. Thank you. You're clearly not in my family. So. No one goes expecting this. People tell me I went to the hospital or my doctor because I thought I had the flu. I was tired. I was short of breath. They think they need vitamins or some kind of medication or an antibiotic. So the result being a cancer diagnosis is shocking, and people describe it very much like people describe a trauma. People say that they've heard one word of what the doctor or nurse has said. They describe very specific details like the texture of a chair or the color of the paint on the wall, and these sort of dissociative experiences. And it's very difficult to integrate all of that into who am I in my life, and what am I going to do with this piece of me, and figuring out this whole new context of which very few of us know until we have to.
So what's the very first meeting after the diagnosis like? Walk us through that. You want to use this one?
No, I think I'm just doing it wrong. Okay, there we go. So, I mean, I could meet a patient at any point, like diagnosis, treatment, or as they transition, people have these emotions come up at any time. I would say with the diagnosis, there's a lot of a before and after. So someone comes in to meet with me, they can present in many different ways. Maybe they're just in like problem solving mode, so they don't have the capacity for these emotions to otherwise, or there's individuals there who the whole session is spent tearful, right? Like tears. But a big thing that comes up is this before and after, this me before and this me after, like this grief of a previous life that has now been permanently shifted.
But what we're learning is, although permanently shifted, it doesn't mean like permanently. Obviously, through the immunotherapy and all of the recent discoveries and so forth, there's a lot of optimism to offer too, right?
Absolutely. I would say in the initial, though, if we're talking initial, there's just a lot of shock. And so to think about actually getting to a place where, you know, Jay, Anne, and Sarah, where there's this point of processing, it's like so far, right? But it transitions over time. And absolutely, I tell patients, you can definitely, you know, we can get you to a place where you're able to cope with this and have a very fulfilling life. But there's time before that.
It must be hard as well for both the patient and the family to even like accept you folks in their life. They're maybe not ready for the discussion, right?
Not everyone's happy to see a social worker, and we get that. People may come to us for different reasons at different times in the treatment trajectory. Sometimes we're talking about practical needs. You know, who's going to take care of my kids while I'm at treatment? How am I going to pay my mortgage when I can't work? Sometimes it's a very practical thing. We talk a lot about building up a toolbox, a practical one and an emotional one. And sometimes over time, the emotional piece comes up, and then we talk about that. Okay, how can we... If you've never had counseling before, that may not make sense to you. And so we talk about it as another potential tool for processing the impact of this, both practically and emotionally.
Give us an idea as to more of the descriptions that patients will give you in terms of what they're experiencing on the inside, so to speak. What seem to be the biggest challenges for them right away?
There's so much variability to that. I would say anything within and beyond a spectrum of I'm numb, I feel nothing, I want to feel things and I can't, and I don't know why, that's not who I am, to someone who's completely overwhelmed and feeling like they can't get through a day, keeping their emotions in check. Again, beyond that as well, and everything in between, I would say.
And I'd add like words I hear a lot of I should, I shouldn't, you know, like I shouldn't, depending on the diagnosis, like maybe there's a good prognosis. You know, I work in the genital urinary clinic, and sometimes testicular cancer can have a very good prognosis, right? And I hear patients say, you know, and you guys have all been in the waiting room, you're looking around, you're looking at other people, wondering what they're here for. But I hear, I shouldn't feel this way. because A, B, and C, I should be feeling this way. So there's a lot of, there's a huge range, right? But almost judgment towards yourself on how you should or shouldn't feel. And there's a lot of different ways we can reframe that and talk about it. But it's not a good feeling to have a cancer diagnosis and then also feel shameful about the way you're feeling.
Strangely, fittingly, within this past week, I lived this experience with a family member, and it is the shock and awe. But then it's like you don't know what to say, you don't know how to act, you don't know what's appropriate. And a lot of that folks have to deal with, not just the patient, but you have to include the family. And what are some of the immediate challenges and reactions from family members? Because Jay mentioned the effects of the family himself in the video.
Again, huge range. It depends on the roles in the family, supports are, who people think are the supports, and then who actually are the supports. Sometimes, again, I probably overuse the toolbox analogy, but sometimes one of the first few tools we're talking about are communication strategies. What do I tell my kids? How much do I tell my kids? What do I tell my partner? How do I explain what I can realistically show up for during this period of my life with so much uncertainty and so much changing demand? So sometimes those are the first things we're talking about, is how to communicate to the people in your life, and sometimes how to communicate to your medical team.
And I would say it's common for family members and the patient to be in much different places, right? Mm-hmm. Someone holds the place of hope, someone holds the place of fear. And so that can be an interesting dynamic when the patient is, I feel like I'm going to die and I need to prepare. And the family member might be, no, you're not. You're going to be fine.
Right.
And so then there's actually anger, frustration when it's like, you don't know that, right? Like, you don't know I'm going to be fine.
Right.
And it feels insensitive. And so the dynamic shift, I normally will say, whatever dynamics were there before, they're probably going to be intensified, right? So the family member that didn't speak, probably not going to speak. The family member that cries, there's probably going to be a lot of tears. So there's a lot of dynamics there.
As if the diagnosis isn't shocking enough, right away, I'm guessing, they're thinking about going forward with life, with job, with family, with children, like Jay mentioned in the video. So that must be overwhelming for them instantly.
I mean, I've had patients who have spouses who are pregnant, right? Like they're in these, they may be up for a promotion. And one thing, and I'll mention this, and then I'll stop. I mean, I'll never forget my very first patient I ever met with was inpatient on Lunder 9. A 98-year-old female, and there was a lot of, someone who's in this age group, maybe they wouldn't want to continue a treatment, right? Like that's to go home and spend time with your family. And I remember I went in and I sat with her, a serious diagnosis and thinking about discontinuing treatment, and she said to me, I have great-grandchildren that I want to see go to school. I want to see them get married. Mm-hmm. I love my life, I love my family, and it shook me because there's an expectation that at a point in life you've lived it, and it doesn't matter how old you are, there's still more to see, and that can be really hard.
Mm-hmm. By the way, at any point in the discussion, if anybody has a question, just pop your hand in the air and we'll get the question in immediately. So at any point, feel free. We're going to take a look at more videos, and if I'm not mistaken, I think we're going to start with Jay. Talking about more of the challenges and the experiences. So let's take a look.
I'm in my 6th year on alectinib, and slowly I am without evidence of cancer now for 5 years as of April 8th. So the metamorphosis, I would say, of going from completely distraught to here I am talking with you all today is slow. I'm using the word metamorphosis on purpose because it's just like a butterfly. You went into a cocoon and suddenly at some point you come out with your full wings. So it was an evolution. And I've done things like volunteer at the PFAC committee here. And you learn that other people are sicker than you, and that you need to think about what it might be like to be in their shoes and how to help them. You do see all the bigger issues relative to health. And those types of things help me a great deal. Seeing other people, being involved in things, keeping my brain working, having somebody at home push me along. And I probably didn't like some of it, but it was good medicine, even though it wasn't medicine. My oncologist here actually introduced me to the social workers who started me on my long path of learning who I was. Fantastic people. And they sorry, they taught me so many things. And I went through any course that they asked me to do. I did any treatment that they asked me to do, and I wasn't afraid of alternatives. So it started with the normal talking with a social worker about anything. They were my private people I could talk about anything with in the world. And as we went through this journey, they gave me books to read. I went and did courses at Benson Henry. I saw a psychiatrist for a while, which I didn't need, and it didn't last long because there wasn't anything to dig too deep in. But I also took a cognitive course. And all those things I found very, very useful.
So it's interesting, in the video there, Jay talks about all the different tools, all the different techniques he used to cope and to deal. But the question I have is, how do you decide which tools or which techniques work for specific patients, so to speak?
Sometimes it's a moving target. I mean, we're really talking about building up individual toolboxes. I say to my patients, I'd like you to each have your own. I can tell you what's in mine, but it may not be useful to you. You know, I'm not proud of it, but on a rough day, I might have ice cream for dinner. It's a tool. It's not a great tool, but it's a tool. So we think about the tools in the box. Some of them are going to be more short-term helpful. Some are going to be more long-term helpful. Some of them aren't going to be helpful at all. But it's really nice to have some choices, especially when the rest of your life doesn't look like it has a lot of choices. And sometimes the only choice we have is how to respond. So it's a lot harder to learn and use a new tool at 2 in the morning when you're in a moment of crisis than in a quiet, private place like Jay with his social worker, of deciding, okay, these are some things I can learn. These are some skills I can develop. These are some people I can identify in my life who are present and supportive and accessible, and thinking about that in kind of a purposive way. Sometimes we're making lists with people and say, okay, let's break this down. What are we going to use here? What are our options? And we can have kind of options that are realistic and less realistic, and find out what's going well and where the gaps might be.
You want to add to that, or?
I echo everything Jen just said, and what I would say is people are coming to us with these tools. We're just helping them figure out what they are. People show up with some pretty incredible coping mechanisms that they've developed through life, but they might not identify it as a coping mechanism. So helping them see what works now, what doesn't, what works in a crisis, and what doesn't. So, but echoing what Jen said.
How often do your sessions happen with patients?
Again, for me at least, Leanne and I work on different services, but for me there's a fair bit of variability. It may depend on what part of the treatment the patient is in. If they're in twice a week, they may want to see me twice a week. I think when I worked in radiation, there was one patient I saw every day. That may have been more than they wanted, but it worked at the time. So we try to be as flexible as we can. The beauty of the role that we have is that we try to meet patients where they're at. The biggest barrier for us is knowing who you are. We want to know who you are. We want to work with you. And that comes to us in many different ways, and we do need to work on that.
Did you want to say?
Yeah, I agree.
Leah? Okay.
I mean, there may be a patient that I meet once and they say I'm fine, initial diagnosis during treatment. And then when they transition into this, what is known as the survivorship phase, all of a sudden I'm meeting with them weekly. And so whereas someone I might have met with, weekly or twice a week during the initial diagnosis, they don't necessarily need me as they've transitioned on. So it varies, and we meet patients where they're at. So whether it's twice a week, every day, or once a month, or every 6 weeks, it varies.
We're going to hear more from Sarah, I think, is up next. So let's take a look at the video screens again.
I found someone who had some medical background in medical trauma or whatever, and I went to see her, and fortunately it was a match. And pretty immediately she had diagnosed me with medically induced PTSD. I mean, I knew something was wrong, and I didn't know what to do with this. I had no idea. I didn't even really understand that someone who had a medical trauma, I didn't even call it that at that point, that this could happen. And so I actually, I was kind of embarrassed. I was kind of ashamed of myself. Ashamed is the wrong word maybe, but I discriminated against myself. I felt stigmatized because I just felt this mental thing about me, even though I know I didn't have a choice in it. I didn't understand why it happened to me. And I couldn't tell my family, and I couldn't tell my friends. So I kind of lived with this burden of this after effect from cancer and my other surgeries on my own with my therapist.
Having seen that and heard from Sarah in that video, what would your approach be? I mean, what seems like internal devastation for Sarah. What would your immediate approach be as social workers?
So I would say a lot of people similar to Sarah come to us not understanding the trauma that they've been through. So the immediate approach is, psychoeducation about trauma and validation, right? So I'll use the analogy frequently, if you were on a train and there was an explosion, how long would it take you to get back on that train? You wouldn't go the next day, right?
Ah, yeah.
And that's what's happened to you. Your life has been threatened, and so there's education, and just I see immediately, and I'm sure you can speak to this too, a relief in that this is normal, and these emotions and intrusive thoughts and lack of sleep, these symptoms I'm having, they have a name, just like a broken ankle has a name. So I do a lot of validation, education, and just normalizing.
Jen?
Again, I would echo what Leanne said, and sometimes I think we're creating a context for people. They haven't lived in this environment. Maybe some have, unfortunately, but for many people, this is a completely new experience. And so we're describing that. I think I probably say 3 times a week, if not more, I promise you're not falling apart. This is a completely anticipated normal response to the experience you're having. And you may fall on the floor, and we will only talk about it differently if you can't get back up. You probably will stumble at some point over this experience, and that's completely fine. We're here to help. You're not alone. There are tools that we can use, and we can build up that toolbox. But it's often just giving people a context and a space to say, it's okay that you're not fine right now. You do not have to be positive every second. In fact, that may be less healthy than having some ups and downs.
We're going to hear more from Anne if you want to take a look at the screens again.
All of the treatment team came together to support me. And I had no idea how extensive that team was going to turn out to be. That was from social work. My social worker came in, the oncology chaplain. I began to be tied into all of the supportive services, all of whom brought every possible way for me to strengthen my mind, my body, and my spirit. And at each time I questioned or doubted or feared, there was somebody else who came and said, here's some other way that we can help you feel, to express what you feel. It's okay to feel what you feel. And they validated each and every one of those feelings every day. So some days I was upbeat and happy, other days I was feeling pretty yucky, and it was okay to feel that way.
What do you folks do to help a patient build a so-called community of support? Like, how do you encourage them, and what are the first steps? And I think it must help to have other people around you that are going through the same challenges and, for lack of a better word, trauma. So how do you go about building that so-called community? I mean, in other fields, we have what we call sponsors and so forth to help you through it. So how do you go about building that community?
Again, there's so much variability. If I meet with someone for the first time, I might say, I'm Jen. Can you tell me a little bit about who you are and what today's like and what was yesterday like, and who are you beyond your disease, beyond this exam room? And in hearing people tell me their story, and if they're comfortable enough to do so, their authentic story, we can think about, okay, what goes well for you? That may be helpful here. What doesn't go so well for you in general, we may need to think about that. And sometimes there's a little bit of, what's the word I want to use? Really, we're kind of looking at ways to connect people with their internal and internal resources available, and also external resources they may not know about yet. Sometimes they're here at Mass General, sometimes they're in the community, sometimes they're online, sometimes it's a book. We try to be as creative as we can to meet people where they're at and work from a place that makes sense to them, that's accessible to them.
Leanne?
And echo everything Jen said, but also it shifts. So there may be a point in treatment where going to a group is a little traumatizing because, people are in different stages of treatment. But I would say figuring out, getting to know the patient, this is where meeting a social worker helps, because I can say, oh, hey, you're in the melanoma clinic. We have a program called Billy's Buddies. They link you up with someone with a similar diagnosis, and you can talk one-on-one. And so it's figuring out what helps this person, because it's hard, because when you walk into a cancer center, they might be like, we have acupuncture and we have massage and we have groups, but that might not be how that person,
May not work for one person what's working for another person, but it doesn't hurt to say, hey, you know what, I tried, and it worked wonders for me.
Yeah.
Give it a shot.
So it's a lot of trial and error. Some people will try something and say, I really didn't like that. And then we look at something else.
Earlier I said, one of the reactions for the immediate family or circle of friends, whatever, is sometimes not knowing what to say. Like I said, I just went through that this past week. What are some of the things or phrases we should never say as a support group or family member, or, educate us on that? I don't want to say the wrong thing.
How many hours do you want to listen to?
I actually ran a group once, and that was our icebreaker. What's the craziest helpful advice you've received?
Yeah.
So, and everybody had one.
Really?
Oh, yeah.
Yeah, and what's interesting is this is a weird point in someone's life, right? Besides all the stuff related to illness, like you might have a dear friend who you've talked to every day your whole life, and then they say something that's so insensitive.
Yes.
And then there's, loss, right? Relationships shift. But I would say it's hard to think of a phrase, because for some patients, you're going to be fine will really set them off. It's like, how do you know that? Do you have a crystal ball? Do you know for sure? But others, they need to hear that. So they want the family member to say, you're going to be fine.
Yeah.
So I wish I had an easy booklet of don't say this, but
We could do that.
yeah.
You know what? Let's do that.
This, then this,
A
no.
book of don't says.
I mean, I think you hit the nail on the head. And it takes years, and so I'll have patients in my office saying, when will this go away? When will we be able to, and I get that all the time, and the reality is like, right now, this is what it is. You're a person made up of a million different parts. This will eventually be one of those parts, but right now it's like the whole pie. And so we go to the immediate crisis. So is it your family members are dropping off 1 billion lasagnas and it's really making you mad because you just want to be a normal person and you don't have enough room in your freezer anymore? Then
I like lasagna.
like, I mean, I've had patients get like second freezers because of all the dinners. And when you're trying, but when you're trying to like not have it consume you and everywhere you look, so we'll go to the immediate, what is it, right? And so a lot of people don't know what to do with illness. They don't know how to respond. They don't. And so it's like creating a dialogue. Like, what do you say to the people in your life? You know, give them direction. They want it. They want direction because they would cope with this differently. And then slowly over time, it starts to build structure. But you're right. It's many years of it consuming your life.